Good evening, everyone. I'm Debbie Hilbisell, and tonight we are going to be doing case list review. And again, we've added the Thursday webinars and extended them for an extra 30 minutes just so we can try to get to more of the candidates. All right, so I'm sure you guys are sick of hearing this, but just real quickly, there's a little orange arrow up in the right-hand corner of your screen that will basically open and close your panel if you need to. It looks like everyone is on computer and microphone, so we don't even need to worry about the, yeah, maybe there might be one person on telephone. So anyway, if you're going to use the telephone, you just put on use telephone and you'll get a phone number, an access code, and a PIN. With regards to volunteering, you don't have to type in questions, you just raise your hand. And with regards to raising your hand, when I call on you, oftentimes you're still muted on your end. I'll unmute you on my end. You just make sure that the underneath the orange arrow, your microphone is, you click it, that you're green and you are unmuted. Now, with regards to participation, the whole reason we're adding these extra webinars and extending the length of them is so that we can make sure everyone who would like to participate and volunteer and be called on has an opportunity to do so. So with regards to that, if you have been called on at all for either case list review or structured cases in the month of September, I'm going to ask you to not raise your hand yet. I've written down all the people who've been called on over the last couple of days, just so we can make sure that we get to the people who want to be called on. Some people don't want to be called on, and that's fine. They'd rather just listen. But our goal is to allow everyone to have an opportunity. So when we get to that point, I'll ask you to please raise your hand if you haven't been called on in September. All right, all of us examiners, we do our the webinars a little bit differently. And I always like to start off with just a little clinical pearl. So one of the things that when I do mock orals that I find the candidates struggle with a little bit is how to counsel patients with regards to hormone replacement therapy, specifically with regards to benefits and risks. And you can even Google up, if you Google up the NAMS position statement on hormone therapy from 2017, it's a 28-page publication, but they really do a nice job of summarizing how we should be counseling our patients, contraindications, risks, etc. So let's just do a real quick review. All right, so in the WHI, when we look at women between the ages of 50 and 59 who did take combination hormone therapy, so an average of almost 6 years of use, or conjugated equine estrogen alone, and there was no increase in cancer mortality or cardiovascular mortality, even after 18 years follow-up compared to placebo. So that is in the women who were 50 to 59. When we also look at that age group, all-cause mortality was significantly reduced versus placebo. Breast cancer mortality was reduced in patients using conjugated equine estrogen alone, and I think you guys are aware of that. And then also, so was Alzheimer's disease or dementia and overall mortality. So the most important thing that they're going to ask you would be things like, what would be contraindications for hormone therapy? So unexplained vaginal bleeding, liver disease, a prior estrogen sensitive cancer, including breast cancer, prior coronary heart disease, stroke, MI, VTE, or personal history or inherited high risk of thromboembolic disease. So how are you going to counsel your patients about the risk of breast cancer? Because that's what frightens them more than anything. And it's really tough when we talk about relative risk versus absolute risk, because when people hear that the relative risk increase is 36% or 38%, they hear 38% of women who take hormones are going to get breast cancer. What they don't understand, it's a 38% increase of what their baseline risk is. So we're supposed to discuss with our patients that one of the risks of hormone therapy for women less than 60 age includes the quote rare risk of breast cancer with estrogen progestin therapy, and that is not seen. If anything, we see reduced with estrogen only. We also know if patients take estrogen with inadequate progestin therapy and they have a uterus, that they're at an increased risk of endometrial hyperplasia and endometrial cancer. And of course, there is a slight increased risk. Again, these are considered a slight increased risk of VTE and gallbladder disease, but we can negate the VTE risk or at least significantly reduce it by doing the transdermal route. So what does rare mean? If we say it's a rare increased risk, it means that it's less than 1 in 1,000, but greater than 1 in 10,000. So you can see the absolute risk increased number of cases per year is exceedingly small. So if they ask you, so if I took hormones for like even a year, how much is it going to increase my risk? Well, it's about 0.001, like by approximately 0.001. Actually, it's even a little bit less than that. Does that kind of make sense what I'm trying to say? So the key points here is the appropriate effective dose of hormones consistent with treatment goals that provides benefits and minimize risk should be the therapeutic goal. And often that's the lowest dose, but it doesn't have to be the lowest dose. We want the lowest effective dose, and that it doesn't really matter if it's transdermal or oral with regards to therapeutic efficacy with vasomotor symptoms. And of course, we already know that different therapy doses and formulations may have different effect on target organs, such as micronized progesterone is I'm going to call it friendlier to the breast. That oftentimes studies done with micronized progesterone did not show even that rare increased risk of breast cancer, as well as it is more lipid friendly. So the attributable risk of breast cancer. So if it's like I told you, it's less than one additional case of breast cancer per 1,000 users annually. The risk is slightly greater. So if your patient is on hormones, her risk is slightly greater than if she had 1 glass of wine a day. That's 4 ounces. It's less than if she has 2 daily glasses of wine. So if she has 8 ounces of wine a day, that increases her risk of breast cancer more than taking hormone therapy. And it's similar with the risk reported with obesity and low physical activity. So I think that's a nice way to put it into perspective. The other thing is, at one of the last webinars I did, we talked about what are some of the things that you can see with congenital syphilis. On ultrasound, you can see hepatomegaly, fetal hydrops, placentamegaly. On X-ray, they see bony abnormalities. They can see things like cortical thinning, problems with demineralization and other abnormalities. And in the newborn itself, the newborn can have, we call it the snuffles, which is just the rhinitis that they get, hepatosplenomegaly, skin rash with desquamation, chorioretinitis, glaucoma, cataracts, the demineralization of the bone. They can have low birth weight, the Hutchinson teeth, which won't show up until their permanent teeth come in, and they can also develop an 8th cranial nerve deafness. So those are my little pearls for today, and now we're going to get going with case list review. So I'm going to see who's not been called on in September, who would like an opportunity to go. All right, Rafif, I believe I've got you. I've unmuted you on my end. No, let's see. Now you're just.
Yeah, I'm
Okay.
I'm here. Do you hear me?
Yep, I can hear you. So now I need to get out of here. Hang on. And then I'm going to go to the case list and let me pull up your case list. Oh, the other thing too, you guys, when I get ready to call on you, if you have a particular case you would like to discuss or a particular case list, please let me know. All right, so what would you like to do?
I'm okay with what you choose.
Alrighty. So let's just start with the GYN.
Okay.
You're a generalist, right?
Yeah, I'm working now generalist, but I'm RAI in origin.
Yeah, that's right. That's right.
Yeah.
But you're functioning as a generalist right now. All
Yeah.
right, let me just take a quick look through here. All right, let's look at patient number 8. So this was a 45-year-old G2P1 who had abdominal pain. She had adenomyosis diagnosed by MRI, failed medical management, and had a benign endometrial biopsy. Tell me, why did you order an MRI on this patient?
Uh, just to verify that there is no other reasons for her abdominal pain because we tried all the treatment with her and it was all non-successful. So just kind of to be sure of the diagnosis.
So what medical management, when she first presented with abdominal pain, how did you evaluate her?
So patients in abdominal pain can be like very broad spectrum of causes. Could be non-gyne and could be gynecologic as big like causes. Under non-gyne could be GI, could be urogenital and urinary system, could be musculoskeletal, could be depression affecting like her emotion, like reflecting on her abdominal pain. But the other way, the gynae could be either infection, cervicitis, like endometritis, could be endometriosis, could be adenomyosis, fibroid. Uh, so it's really ovarian mass. It's big spectrum of causes for abdominal pain.
Okay, if somebody
Most of the
has,
common, I'm sorry,
go
go
ahead,
ahead.
go ahead.
Most common causes are endometriosis, interstitial cystitis, adhesive disease, IPD, like inflammatory bowel disease. Those are the main common causes, but it's a very broad spectrum.
Clinically, how does someone with adenomyosis typically present?
It's mainly pain during menstruation, pain during sexual function. That's the
Okay,
main cause, of, like symptomatic, and heavy menstrual bleeding sometimes.
okay. On physical exam, what would make you suspicious for adenomyosis?
So tenderness when you do the exam of the uterus, uterus can be enlarged, maybe like especially in the anterior posterior diameter, kind of barrel shape. Ultrasound also might direct you towards adenomyosis.
Okay, all right. And so even before the MRI, but you confirmed with MRI that adenomyosis was indeed present. So you proceeded with a hysterectomy because she failed her medical management. So you did a TVH. Why did you do a BSO on her?
So actually, I want to apologize for this is a typo. It's BS, not BSO. And as you look into the pathology, there is no ovarian tissue in
Okay,
the
that makes me feel better.
yeah.
Okay, because yeah, because why would you not recommend removing the ovaries in a 45-year-old menstruating woman?
So the ovaries are like even this patient was not menopausal, but even in menopausal patients, the ovaries is like keep on secreting low doses of estrogen, and that reflects on the patient health, on osteoporosis, in heart disease, in length of expectancy of life. So when we are like doing oophorectomy at early age, we are exposing the patient to affecting the long like the length of her life, and it affects more osteoporosis, menopausal. It gives her surgical menopausal, so it's affects more cardiac disease, heart disease. It will be in higher risk for these all of these.
If for some reason you had to remove her ovaries, maybe there were bilateral teratomas or whatever, for some reason you couldn't or you decided not to save her ovaries, maybe patient anxiety. Tell me, if you had a 45-year-old that you made surgical menopause, what would you recommend for her and why?
So I would recommend if there is no contraindication for if there is no contraindication for using the estrogen, I would recommend estrogen replacement therapy in these cases. No need for progesterone since the uterus, if the uterus is like hysterectomy, like what I did for this patient. Mainly, first of all, we have to rule out any contraindication for the estrogen.
Okay, and what dose, let's just say there was no contraindication, you're going to start her on estrogen therapy. What dose would you start her on?
So estrogen could be like in different modalities, like pharmaceutical, could be oral. We prefer more like to avoid oral to avoid the like effect on the liver, and patch is the best way to go on. And if there's only let's say it's not the BSO, let's say like just we're talking about ERT. Also, if the main problem is in her sexual function and dryness of the vagina, also we could provide a vaginal route.
Okay, but if somebody was 55 with vasomotor symptoms versus 45 that you made a surgical menopause, would you start them on the same dose of estrogen? Why or why not?
I would say that 55 will be less dose. Uh, to be honest, I'm not sure about the difference in the dose, but I would expect it might be less dose because the patient has less demand of estrogen. Her body used to less dose, but I don't know, to be
Yeah,
honest.
yeah, and that's right, Rafif. I mean, sometimes it's good to think out loud, and even if you're not sure, you could say, you know what, I'm not sure, but to me, I would think you would give the postmenopausal woman less estrogen and more to the premenopausal that you just made surgical menopause.
Yeah,
You may not know the actual dose, but you talked out your thinking point, and that is correct thinking. And so when you make somebody surgically menopause, we want to try to put back like a physiologic dose for all of the health benefits. Whereas when somebody's 55 with vasomotor symptoms, we're truly trying to control the vasomotor symptoms. So oftentimes we will start with the lowest dose and just nudge it up in order to control symptoms. Here, we're trying to prevent cardiovascular disease, osteoporosis, cognitive impairment, and killing the woman earlier, right? I mean, we're
yeah,
trying to,
I
not
agree.
reduce. So you should really consider starting them on like double the dose you would the menopause patient. If this was my patient and I was going to start her on a transdermal estrogen patch, as a minimum, I'd have her on the 0.075, wait, yeah, 0.075 or the zero point 0.1 milligram per day.
Yeah.
Okay. All right.
Okay.
Now, one more quick question. You did a TVH. How are you going to suspend that vaginal cuff so that you don't, she has less chance of vaginal vault prolapse in the future?
Uh, Usually, whenever I do TVH, I do modified McCall, which is like suspending the vaginal cuff to the uterosacral ligaments.
Okay. And so when you do that, what's the likelihood? What's the risk of that? Where are the ureters when you're doing that modified
So
McCall
the
cultoplasty?
main complications for McCall or modified McCall is clinking the ureters, kinking of the ureters, and that's why we always do cystoscopy after that because the ureter pass lateral, almost 1 centimeter lateral and posterior to the uterosacral ligaments. And one trick we can do it, which is pulling the string or the Kelly that we have packed the uterosacral ligaments stump to it, we pull it on the opposite direction towards us and to the other direction. This way, we make it away a little bit from the ureter and we take our stitch medial in the uterosacral ligament.
Okay, great. All right, thank you. I don't have any further questions. Any questions for me?
No, just I need the dose for, like you said, for both ways. Like,
Yeah, and yeah, just review your dosing for the low dose that you would start, and then basically you want to do a double dose, or the two higher doses would be for the surgical menopause patients.
okay,
And ACOG does say that. ACOG does say when we make somebody a surgical menopause, it's not, they don't even say you can offer it to them. They say you should put them on estrogen therapy until the average age of menopause. So,
is
all right.
is the patch of one microgram is fair for this case?
Mm-hmm. Yeah. So now you got me. It's wait. It's 0.05, wait, 0.025, 0.05, 0.075, and zero point 0.1. Those are the doses. So I'd go with the two highest doses.
Okay, thank you.
Okay. Thank you. All right. So it looks like. Oh wait, here's someone else who hasn't gone yet. All right, Dr. Savita. If you can unmute yourself, that would be great.
Hi, are you able to hear me?
Yep, I can hear you. So how you doing?
Good, how about you?
Good, let me find your case list. Any particular case or case list you'd like to cover?
I guess we can do OB.
All right. And are you a generalist
I am in fellowship training.
for
MFM, sorry.
MFM?
Yeah.
Oh, no fair that you, no, we're not doing OB. We're going
The only reason I picked it is because it's my first time being on the hot seat, but we can do something else.
Okay, okay. Let you get away with that then. I was like, no way. That's like asking infertility to a REI patient or to a REI candidate. Let's see here. All right, let's just kind of just go through just so that you can feel comfortable doing some stuff. Let's just look at patient number 6. So you have a 39-year-old G2P0. She's got advanced maternal age, hypothyroidism, and as well as when you did her GBS screen, it was GBS positive. So let's start with first things first. When you have somebody who has who comes in who's AMA, how do you counsel her about the risks of AMA in pregnancy?
Can you hear me?
Oh, now I can. Yeah, you were muted for. I was like, oh my gosh, she hung up on me.
No, sorry, I was trying to like go back and unmute. So you were asking about the risk associated
Yeah,
with AIM during pregnancy.
correct.
So really when you're talking about kind of risk related to any individual factor for a patient, I like to kind of think through kind of maternal and fetal and obstetric risk that you can have. So from maternal standpoint, with advanced maternal age, you can have an increased risk of developing hypertension and diabetes during pregnancy. You can also have an increased risk of requiring a C-section, which is one of the obstetric related risks. And then from kind of a fetal perspective, one of the things that we highlight is the increased risk of aneuploidy with advancing maternal age.
And what sort of aneuploidy screening do you offer all of your patients, and do you do anything different for your AMA patients?
Yeah. So for all patients who present for obstetric care, we do offer non-invasive screening with cell-free DNA screening beginning at 10 weeks in the pregnancy. And typically at my institution, we also do a nuchal translucency screen. And then for patients who have advanced maternal age, actually for all patients, you can electively offer to have diagnostic testing as well during the pregnancy. And for patients who do have advanced maternal age, that's something that I actively encourage them to do as well.
Okay. If this patient had a cell-free DNA that came back high risk trisomy 21, what would you counsel her about the likelihood that that is a true positive versus a false positive?
Yeah. So NIPT is specifically a really great test to assess for trisomy 21. So I think that the sensitivity for trisomy 21 in NIPT is about 98 to 99%. And so one of the things that we look at after we look at a sensitivity of the test is like the positive predictive value to see, what is a likelihood that that is truly positive. And I think that definitely varies depending on a patient's age, but overall it's thought to be pretty high again for trisomy 21 using NIPT. And so whenever we do a screening test during pregnancy that comes back positive, we always recommend doing diagnostic testing, either in the form of CVS or amniocentesis, just to give us confirmation.
Okay, with regards to her hypothyroidism, let's say this patient comes into her new OB visit with a history of hypothyroidism and she's currently on levothyroxine. What are you going to counsel her about the importance of adequate thyroid control during pregnancy?
So you mean like in terms of how I would monitor her during the pregnancy,
Well,
or?
no, like what? Yeah. Well, yeah. So go ahead and we'll talk about how. Let's do that first. Tell me how you're going to monitor her, and tell her why it's important that she has good thyroid control during her pregnancy. What would be the risks of untreated or undertreated hypothyroidism?
Okay. So in terms of the actual management of hypothyroidism during pregnancy, if she is already on medications to control her hypothyroidism, that's something we typically monitor kind of throughout her pregnancy with serial TSHs in order to continually titrate the medications, because as the pregnancy advances, the adequate the amount of medication she may require can change throughout the pregnancy. And so the way that we monitor that is by getting TSHs and then titrating the dosage accordingly.
Tell me where you want that TSH to be.
Typically, you want TSH to be less than 2.5.
Okay. If you did a TSH at her new OB visit and it was 1.9, so when are you going to do her next TSH?
So if I'm not making any titrations to her medications, then I would check it on in every trimester. And with a TSH of 1.9, I wouldn't make any titration, so I'd probably check in again in her second trimester. If I was making titrations, then I would consider doing it on a monthly basis.
Okay. All right. So now let's go to what are the risks of untreated or undertreated hypothyroidism?
With undertreated hypothyroidism, you kind of first take on the maternal risks of developing, symptoms related to hypothyroidism, which are multifold and include things like having significant fatigue, having weight gain during the pregnancy, having like hair loss associated with hypothyroidism, and then being euthyroid throughout the pregnancy is also important for fetal development, specifically fetal neurologic development. And so with untreated hypothyroidism, you can sometimes see cognitive effects in the neonate. And then, so that's certainly something that we treat hypothyroidism for, with the hopes of both avoiding any maternal symptomatology, but also making sure that, the neonate doesn't have any effects from untreated disease.
If somebody presented with hyperthyroidism, tell me what medications we treat in pregnancy and why.
So within the two medications to treat hyperthyroidism are PTU and methimazole. And PTU is frequently used within the first trimester, while methimazole is used in the second and the third trimester. And then when we're thinking about risks associated with the medication specifically, PTU is, and I'm sorry, I'm going to have to definitely review this because it's been a while since I've looked through this information, but PTU is associated with potential significant hepatic impairment. And so we really try and use that for a limited period of time as possible. Whereas methimazole can have some hepatic toxicity, but the thing that we think about really is agranulocytosis, which is a more rare risk. And honestly, now that I've said that out loud, I may have flipped the two medications. So definitely something that I need to look up.
Oh, no, you didn't. But what about congenital? What about for the fetus with methimazole?
With methimazole during the pregnancy, let me just take a moment and think. I don't know at the top of my head. With methimazole and congenital related effects.
Mm-hmm. It can cause like congenital anomalies like that what is it, the skin lesions, and it can cause like different embryopathies.
Yeah,
Yeah.
definitely something
So,
we need to review.
yeah, no, and that's okay. And you know why the reason I brought it up is because one of the things I recommend to everybody, and forgive me if I'm saying this again, but I think it's important. If you look at the ACOG practice bulletins, over the last 3 years, they have updated a lot of just basic obstetrical practice bulletins like herpes in pregnancy, obesity in pregnancy, fetal growth restriction, protection and prevention of preterm birth, gestational hypertension, etc. So I'm not saying I want you guys to go through and read those bulletins from beginning to the end, because it's going to make your head swim with the amount of information in it. But what I would like you to do is know, why did they update it? Why did they feel it was important? And for instance, they just updated it in the last 12 to 18 months, thyroid disease and pregnancy. So I was like, well, why did they update it? Basically what they said, the only thing that changed was the hyperthyroid stuff. The hypothyroid is the same. The hyperthyroidism, they discussed that we've always recommended PTU in the first trimester, but we limited its use in pregnancy because of concern for hepatic dysfunction, or really we would see almost like a medication-induced hepatitis that was much higher in pregnant women for some weird reason. And so that's why they then recommend that we went to methimazole in the second and the third trimester. The reason we didn't just do methimazole the whole time is because during periods of organogenesis, methimazole can cause different congenital like anomalies with, I don't know why I'm thinking about that. I think it's called aplastic cutis or something. It's like skin lesions. And I know there's some other things that can cause that I'm blanking on right now. But then in this practice bulletin, it said that the risk of like medication-induced hepatitis has been over, like it's not as big near the risk that they thought it was. And so now they say you can actually give PTU throughout the whole pregnancy if you so choose. That's the only difference in that whole new practice bulletin. So my point is for you guys just to go through and make sure you're aware of what is the new update they said. Why did they publish a new one? And that would bode well for you during the exam. So look at the A, B, and C recommendations. All right, good. All right, sounds good. Thank you so much.
No, thank you.
Any questions for me?
No, it was really great to practice out loud, so thank you.
It's anxiety-fying, but you did a great job. You have a very good exam style, so don't worry about that. And you, even when you were like, I think I would have to review or look that up, you didn't lose your cool, so that's good.
Thank you.
So I think let's get Matthew. Hey, Matthew, how you doing?
Good, how are you?
I'm fine. Let's see here. Let's pull up your case list. So what would you like to do?
I think I would actually like to do an OB case with my vacuum deliveries.
Okay. So let's see. That's a waist operative vaginal delivery.
It's like in the 40s or 50s, I think.
Yes, let's see here.
Maybe later.
Well, no, I was going to say, is it under? Okay, so is it under? Okay, got you. All right. So which you want me just ask you on either one, or is there one that you're particularly concerned about?
I guess we could do case 59.
Okay, all right. So you have a 25-year-old G1P0 at 37 and 2 who comes in with, so she's got what, gallstones and gallbladders acting up?
Yes.
Okay, and so is she coming in with right upper quadrant pain?
She is. She was known to have at least some sort of gallbladder disease and stones throughout the pregnancy, non-compliant with dietary restrictions, and had multiple triage visits for right upper quadrant pain.
Why
So
do we see higher risk of gallstones in pregnancy?
there's decreased the sphincter of Oddi dysfunction, or decreased function, I guess. So there would be decreased also contractility of the gallbladder, which leads to gallbladder sludging and increased risk of gallstones.
Okay, and does the high hormone levels also have to do with like, you know, we know that OCPs can increase the risk of gallstones. In pregnancy itself, there's increased risk of gallstones. I'm pretty sure, and actually haven't thought about this in years, but the elevated hormones also have something to do with like bile stasis and increased risk of stone formation. So it has something to do with that. So you're right. One of the things we want to do is we want to, as best as possible, control this with diet. What type of a diet do you recommend for someone who has gallstones that occasionally are symptomatic?
We would recommend a low-fat diet.
Okay, why is that? Why would a low-fat diet make any difference?
Because the bile binds to lipids that then are used for transport into the across the gut into this throughout the body cavity, throughout the body.
Yeah, the other thing too is when we eat a fatty meal, you know, we get secretion of digestive enzymes, and the enzymes that break down the fat are what's stored in the gallbladder. So you're going to get, you know, contraction of the gallbladder. That's going to, you know, aggravate stones, try to push them out into the gallbladder duct and things like that. So low fat diet. All right, so MFM says we need to just go ahead and get this patient delivered. So you induced her. She was going along, and at some point in time, a non-reassuring fetal heart tracing developed. Could you describe that tracing to me?
Sure. The patient had a category 1 tracing for the majority of her induction, but as she progressed to 10 centimeters dilated, there was noted to be a prolonged fetal decel, at which point she was evaluated at the bedside. I was determined to have made a significant cervical change, and we elected to proceed to the operating room, where it was noted that the fetal heart tones improved. So she was counseled appropriately regarding continuing with vaginal delivery. And given the category 1 fetal heart tracing, she began, you know, with maternal pushing efforts.
Okay, so she had this prolonged deceleration. Take her back to the OR. There's a recovery of the heart tracing to back to a category 1, correct?
Correct.
Okay, so then you stay there, the mother continues to push, and then, so what was your indication for vacuum delivery?
There was noted to be, at one point, there was noted to be recurrent late decelerations towards the end of her pushing efforts. But they did recover, and then eventually there was non-reassuring fetal heart tones that did not recover appropriately. So vacuum, prior to this point, however, we had discussed the possibility of a vacuum delivery, given the you know, movement to the operating room. And then with her kind of terminal pushing efforts, there was known to be non-reassuring fetal heart tones, at which point a vacuum was applied and vacuum delivery was achieved.
Okay, all right, so with regards to a vacuum delivery, what needs to be in place for you to feel comfortable that you can safely apply a vacuum?
Sure. So obviously appropriate counseling for the patient with the potential risks and benefits of vacuum-assisted vaginal delivery needs to be accomplished. Adequate anesthesia needs to be applied +2 station or greater of the fetal head. A recent estimated fetal weight also needs to be known, and position of the fetal head also needs to be determined. An empty bladder would also be useful, and also a plan to abandon the procedure with an alternative method of delivery.
Okay, and what would be contraindications to a vacuum?
Contraindications would be any known or suspected bleeding disorder of the mother or, the mother or the infant, specifically, well, for example, like von Willebrand's disease, and then high fetal station would also be at least a relative, if not a firm contraindication to vacuum. And rare causes could be like osteogenesis imperfecta, also prematurity and low estimated fetal weight.
Okay, and then what would you consider a failed vacuum?
A failed vacuum, from my standpoint, is 3 pop-offs that have been previously adequately applied.
Okay, and run through the maternal risks and fetal risks.
So maternal risks would be increased risk of oasis injury, 3rd and 4th degree lacerations, or vaginal lacerations. That's the primary risk for mom. Of course, a failed vacuum delivery, which would require likely a cesarean section. Fetal risks would include increased risk of intraventricular hemorrhage, bruising, hyperbilirubinemia. Yeah.
Okay, all right, so now why do you think this baby was a 1 in a 4?
Towards the end of the pushing efforts, there was noted to be a tight nuchal cord, and since she was a primiparous patient, it did still take some effort to achieve a vacuum-assisted vaginal delivery. So it's possible that the infant had some element of hypoxia.
What was the 10-minute APGAR?
I believe it was still a 4.
Okay, do you know what the 20 was?
I don't know.
Okay.
Yeah, I
Okay,
don't know.
did you do cord gases on this baby?
I did.
You
Yeah,
did or did not?
I did, yes.
Okay, and what were they?
6.9, I believe, was the arterial.
Okay, and so is that good or bad?
That is not good.
Okay, yeah, that's not good. So anyway, how did this baby went home in 3 days? Was there any evidence of hypoxic encephalopathy or anything like that?
There was some evidence of it, and unfortunately, I don't have access to the fetal records, given that it is a different hospital system, and I would not be privileged to this patient's information. So I don't know, unfortunately, don't know here.
Okay, yeah. So I guess the main point here is if the 5-minute APGAR is 5 or less, ACOG wants us, or ABOG wants us to list a 10-minute APGAR, and they really say we should continue. If it's still that low, you should get a 15 and maybe even a 20-minute. For sure, with a case that is like this, a category 3 tracing or low APGARs, it's good to get an umbilical cord blood gas, and yeah, anything less than 7 is not good, and any base excess greater than 12 is not good. So there was obviously a combination of what metabolic and respiratory acidosis. Yeah. And so in hindsight, is there anything that you can think that you would have done differently?
Given the patient's premature state, I would have considered also strongly advising towards possible cesarean section. Given the prolonged fetal decel and other possible recurrent decelerations later in the pushing efforts. I would
But
have also,
I'm going to interrupt. That is a tough call when she had a prolonged decel and then it wasn't there. I mean, sometimes just compression of the fetal head, if there was a rapid descent, you know what I mean, can temporarily cause a deceleration and then it went back to normal. And if it was truly good variability category 1 tracing while she's pushing, and it wasn't until the very end again that you all of a sudden started having these decels, I can totally see where you're like, well, let's just get this baby out. You know, you didn't anticipate a tight nuchal cord. But in hindsight, you're saying maybe you should have stuck with your first gut response, and when you took her back to the OR, just do it.
possibly, yes.
I know it's a tough one. It's everything we do is a judgment call, because when it recovered, you also were saving a primip for almost being doomed to repeat C-sections too, because not very many people do VBACs anymore, or patients don't want to. So what is your concern on this one, the APGARs?
Yeah, I think so.
Yeah, and I get it. And I think that that's what, if you just explain your thought process that you initially had this prolonged deceleration, but the time you went back, you reevaluated the fetus before you jumped in to do a C-section, and the heart rate had recovered, had good variability, normal heart rate. So you had everything prepared to do the C-section. You stayed in the OR, continued to let her push, and it wasn't until the very end of pushing that she developed recurrent late decelerations. At that point in time, you could safely put a vacuum on, and you felt that the vacuum was actually more expeditious in a way of getting the baby out than even going to a C-section. You know what I mean? Because you could, and that you really didn't anticipate the APGARs being that low. And then if they ask you about cord gases, you can talk about that. But everything else, I mean, I think that's how I would approach it. Hey, I did quick look this up. It says women are at higher risk of gallstones, and that risk, pregnant women, and that or any woman is, than men, and that risk increases during pregnancy. Increased hormones during pregnancy can cause higher cholesterol levels and delayed gallbladder emptying, which can lead to the formation of gallstones. Nearly 8% of pregnant women form new gallstones by the 3rd trimester, but only about 1% have symptoms. So anyway, so it's a combination of the higher hormone levels causing higher cholesterol levels, and then the delayed gallbladder emptying, and those two together increase the gallstone formation. And now we know.
Okay.
All right, great. Thank you. Any questions?
I guess my biggest concern with the APGARs as they are, what would you say is the level of detail that I need to know regarding cord gases?
So, I mean, I think you should know the pH and the base excess. You mean for this patient or just in general?
Just in general, like if they were to say, okay, I understand you got cord gases. What does the pH indicate? How do you calculate, base excess? Like how technical do you think you would need to know how to interpret cord
Right.
gases?
It's always hard to anticipate what an examiner may or may not do. I will say you should know what is a normal pH and normal base excess, what is an abnormal and worrisome one that would be indicative of hypoxemia, as if they actually gave it all out to you and say, well, how much of this was a respiratory acidosis? How do you know when this went to a metabolic acidosis? I think that would be extremely unlikely that they would go into that detail when they've only got 30 minutes to see if you know how to manage postpartum hemorrhage. Do you know what I mean in a shoulder dystocia? And if they did go into that amount of detail, it certainly is not going to be a pass-fail thing. It must be because you're flying through everything else that they're just trying to see the extent of your knowledge. Does that make sense?
Yes, thank you.
Okay, yeah, don't like lose sleep over how to calculate that. All right. Okay. All right, so let's see if there's anyone else. Otherwise, hang on here. All right, good. So what I can do then, I can open it up to anybody. So anybody who would like to go, because everybody else who wants to go and has not been called on this month has already volunteered. So let's look for any other volunteers. And I'll just start going through the list. Hey, Danielle. Dr. Myers, I'm calling on you. How are you doing?
I'm good. How are you?
I'm actually really tired, but thank you for asking. I'm trying to be enthusiastic here. All right, so tell me what case list or list you would like to do.
We can just go in order and do like office next.
All right, sounds good. Sounds good. And are you a generalist?
Yes.
Okay, all right. Let me go toward the end. We always get stuck toward the beginning. Nobody looks at the end. All right, let's just look at patient number 35 because I'm going to kind of play with this a little bit here. So you have a 73-year-old who has a history of postmenopausal bleeding. When did she have CIN1? What was the significance of adding that to her problem list?
So this was a patient who had actually seen a partner of mine 2 years prior to me seeing her. And at that workup, she had postmenopausal bleeding, and that provider had done a pap smear. And she subsequently underwent colposcopy for the abnormal pap smear, and it came back positive for CIN1.
Okay, so and that was a few years prior, and she, I'm
Correct.
guessing, had an endometrial biopsy that was benign, correct?
It was benign at that time.
Okay, and then no further postmenopausal bleeding until she presented to see you?
Correct.
Okay, all right. So she comes in with postmenopausal bleeding. Tell me what's your differential diagnosis?
So my differential diagnosis for postmenopausal bleeding includes like atrophy. It also includes potentially a polyp. Cancer malignancy is included in that, as well as hyperplasia. You could have an abnormal like cervical cancer if they had not had appropriate screening prior. It could also be vaginal cause. Those are the big things I think of.
Okay, so let's talk about her postmenopausal bleeding. So she comes in, you do a history and physical, knowing that she had an abnormal pap a few years prior. You repeated your pap with co-testing. You didn't do the colposcopy right off the bat, right? I mean, you waited till you got the pap back.
Correct.
Okay, when did you do the endometrial biopsy? I guess I'm trying to figure out, let's erase the abnormal pap part, just postmenopausal bleeding in and of itself. Somebody comes in with that history, you do a history and physical. Tell me how you're going to evaluate that component.
If a patient presents to me with postmenopausal bleeding, I typically try to obtain my endometrial biopsy at that time to rule out hyperplasia or malignancy, unless they've already had from an outside source a transvaginal ultrasound as part of their workup, which demonstrates an endometrial lining less than 4 millimeters.
And so because what's the most common cause of postmenopausal bleeding?
Atrophy,
Atrophy of what?
the endometrium.
Okay, and so when we do an ultrasound, if we do a ultrasound first and you see an endometrial lining homogeneous 4 millimeters or less, we can assume the bleeding is from an atrophic endometrium, right? So if they
Correct.
come in and your first goal is to do an endometrial biopsy on everyone, I'm guessing you might be getting back some endometrial biopsies that say tissue insufficient for diagnosis, correct?
I haven't actually got that many back saying insufficient, but that would be a possibility.
Okay, and then what would you do if you had that diagnosis?
I would then offer them to screen with a transvaginal ultrasound.
Okay, good. All right, so anyway, so you did her endometrial biopsy and it comes back high-grade serous endometrial carcinoma, correct?
Mm-hmm. Yes.
So, quick question. Why'd you bother doing a colposcopy biopsy and ECC when you knew she had endometrial cancer?
So to elaborate on this for the timing for this patient, I obtained her PAP first, which came back atypical glandular cells of undetermined significance. And then I brought her back into the office and did the colposcopy and endometrial biopsy at the same time to work up both.
But I thought she came in bleeding.
She did come in bleeding.
So I thought you said you do the biopsies when they come in bleeding.
Because this patient also had the history of having the abnormal
Okay.
pap smear, I
Okay.
evaluated both.
Okay. So she comes in bleeding. You said, I'm going to do your pap smear and wait till those results come back. And then what if the pap had come back normal?
If her pap had come back normal, she would still need the endometrial biopsy.
Okay.
But
So
we
her
were trying
bleeding,
to do everything more succinct, I guess, together. Because if she
okay.
needed a colposcopy and needed endometrial biopsy, we're going to try to do it all at once versus multiple things.
So was she bleeding much when she presented to you?
She actually wasn't.
Okay. All right. Was she bleeding at all?
Not on my examination.
Okay, all right, then I can see that there. Okay, I'm just giving you a hard time, Daniela, just
No,
because
that's okay.
I'm supposed to practice doing this. I hate doing it because I'm like really nice. So it's hard for me to be like, okay, well, why would you do that? I mean, like, why'd you do that? So anyway, but you're handling it great. So just so you know.
Thank you.
But yeah, but you can see where they could maybe turn this and go, wait, what? Why did you do this, or how did you do this? And now, but stick your ground. This is what she came in with, a history of postmenopausal bleeding. She was not bleeding at the time. She had had a previous bleed just 3 years before that. The endometrial biopsy was negative, but she did have the SIN1 PAP. So in your evaluation, with there being no bleeding going on at the time, you repeated the PAP and figured you would wait until that came back. You knew you were going to bring her back for an endometrial biopsy anyway, even if the PAP was normal. And if the PAP was abnormal, then you could go ahead and do the colposcopy biopsy at the same time. Now, she had the high-grade serous endometrial carcinoma. So did this patient have any risk factors for endometrial cancer besides just getting older?
Actually, age was her only risk factor. She did not have a family history or anything to explain it.
Was she normal weight?
She was normal weight as well.
Yeah, and again, so because you don't expect a high-grade serous endometrial carcinoma, and that's that type 2 endometrial cancer that is very aggressive and not associated with, it's not a global pathology. It's not due to low constant unopposed estrogen, etc. So here's somebody who comes in, you wouldn't even be thinking endometrial cancer. So I would also, if they presented this, you could say this was a patient who, you know, not on hormone therapy, normal weight, very healthy, da 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 da, and that even more so explains like why. Whereas if she was morbidly obese and she's telling you she had some bleeding, you might have done the endometrial biopsy and while she was there, while you were then waiting for the PET, because your index of suspicion would be so high. So that makes way more sense, even again with this one. So the poor thing, so now she's going to go off to GYN oncology. What surgery did they do on her?
So she ended up getting a full robotic hysterectomy with bilateral salpingo-oophorectomy, and she was found to have stage 3 cancer.
Aw, and so how are they going to treat her?
She would be treated with chemo and radiation.
Okay, all right, good. All right, I have no further questions. You did great. Do you have any questions for me?
No, I think it was just really helpful because seeing how it could, you know, in my brain, you know, I see the patient and I know exactly what I did and kind of why I did it. So I think it was really helpful to have you kind of challenge me a little bit more so that I could see how potentially they could think of it one way versus what I was trying to portray, if that makes sense.
It makes total sense because I do case list reviews, you know, where I'm looking at the cases and I'm dictating and stuff. And there's some things I'm like, oh my God, what did they do? I don't understand this at all. And I'll be explaining that to the candidate um, in my dictation, and then they'll send me an email and patient number such and such, I did X, Y, and Z. And I'm like, well, duh, that makes total sense. Here would be a better way to list that. Or I don't think you need to list anything differently here, but to be able to explain it, I think that's great. So I think you did great management. And it's just too bad the patient was already stage 3, but with that high grade serous, it is what it is. Hey, going back to this high grade serous, also like high grade serous and like the clear cell endometrial cancers, this is why we feel that even tubal ligation or hysterectomies can decrease the risk of ovarian cancer, because some ovarian cancers we do think originate from the endometrium, and it might be some of the the clear cell and some of the high grade serous kind. So anyway, it's just interesting. All right, thanks, Daniela.
Thank you.
All right, so let's see here. Aaron. There you go. Hey, Aaron, how are you?
I'm good. How are you?
Good. So where do you want to go?
I'm in GYN oncology.
And you can't say Disney World.
I wasn't gonna say that, but we can do OB or office.
Okay, all right. Let's do OB because you're a GYN onc and this is probably the furthest from your world. All right, so let's see here. Let's look at patient number 15. This was your 35-year-old who AMA, she has a history of a previous cesarean placenta previa. She's also had an abdominal myomectomy, and she presented with 3rd trimester painless bleeding, obviously from her placenta previa. So with a history of a previous C-section and a placenta previa, what's something you need to be thinking about of what other complications could be occurring?
I would be most concerned about placenta accreta spectrum disorder with the prior cesarean delivery and especially the previa. Both are major risk factors for accreta, especially the presence of the previa.
Yeah, and so how would you evaluate for that antenatally?
Typically, these patients would have a transvaginal sonogram as well as typically an MRI with typically like a multidisciplinary coordination of care between maternal fetal medicine, oftentimes GYN oncology, anesthesia, and pediatrics teams for planning.
And with regards to what would you actually see on ultrasound that would make you suspicious for placenta accreta spectrum?
Typically, the sonographic findings include loss of the myometrial like border and plane between, especially if it's an anterior placenta, between the uterus and the bladder, potentially even just frank evidence of invasion and vascularity that invades through the bladder wall. Sometimes the placenta can appear moth-eaten, or there can be large placental lakes, and then increased vascularity in general can also be seen throughout the placenta. I think those are some of the major findings that.
All right. Okay. And so in this case, there was no evidence on that on antenatal imaging, correct?
She did not have her antenatal care with our institution. She had just arrived to the United States.
Okay, so this was like prenatal care in another country, presents to your ER with third trimester painless bleeding.
Yeah, she had probably been here for like a week or so, but yes.
Oh, okay. All right. So when you're going in to do this cesarean, how do you know if what did you do to anticipate a possible undiagnosed accreta?
Well, certainly just based on her presentation, she was probably admitted for no more than 12 hours before her delivery ultimately happened. She sort of presented with a sentinel bleed, was stable, with a goal of sort of getting some steroids on board and trying to get imaging done, which was not able to be done in that short period of time. So intraoperatively, since we didn't really have time to assess otherwise, preoperatively, intraoperatively, certainly concerning signs for an accreta would be like a ballooned out lower uterine segment, sort of increased vascularity, or just frank evidence of placentation and invasion into other structures that you can feel prior to performing the cesarean delivery. Thankfully, in this case, we did not see or note any of that, and just with her, second bleed after the sentinel bleed, she of course required urgent delivery, and so the decision was made to proceed with a classical cesarean delivery to sort of provide sort of the safest plane away from the previa to deliver the infant as quickly as possible, and then assess the placenta and its safe delivery. We of course let anesthesia know, and also had multiple units of blood available, and had done her labs serially since her admission to have an understanding of where her hemoglobin, platelets, and coagulation factors were all starting with preoperatively.
Okay, so who was the person who had to try to remove the placenta? Was that you? I'm kind of teasing you. It's like who's gonna take their hand off the grenade,
Definitely, it was. I think it came out easily, but certainly. Okay. Her EBL was, I believe, like 1,500 to 2,000, and so just hitting that mark was transfused intraoperatively. But I don't believe she was transfused postoperatively, and she did well from a postoperative standpoint.
And if you had started to try to manually remove the placenta, and you met any type of resistance or lack of a plane, tell me how you would have managed that.
So this is obviously a scary situation, and one in which you don't want to tug on the placenta more, because sort of avulsing it can lead to very heavy onset bleeding from any of those open-ended arterioles that are now eviscerated if you've torn the placenta. So in this situation, I think the best course of management would be to, definitely call for help, have other people assess sort of what the placentation looks like. And if there's concern that this is more than a focal accreta and something where the placenta cannot be removed safely, then discussing with the patient, if she's awake and just under epidural anesthesia, the need for both transfusion if there's heavy bleeding, but also the need for a cesarean hysterectomy would probably be unfortunately the next mode of action if there's concern just based on the clinical exam that this is an accreta.
Okay, and then with regards to, this is going to seem like a silly question, but with regards to antenatal corticosteroids, I'm guessing she was able to get both doses in. She probably presented with that first bleed, got her first dose, got her next dose 24 hours later. Why do we give antenatal steroids?
Antenatal steroids are beneficial for the fetus for mainly fetal lung maturity, but also for reducing the risk of intraventricular hemorrhage and necrotizing enterocolitis and respiratory distress syndrome for preterm. Okay.
And up to what gestational age do we typically give antenatal steroids?
So if they're receiving their first course before 34 weeks, then that would just be it. They wouldn't get any further, but if they've never received any, then they could get them between 34 and 36 and 6, as this patient was in that time period. She had not received steroids prior to this admission.
If you had to do a hysterectomy on her, do you typically leave this, if you had done a C-hist, typically leave the cervix or take the cervix, and why do you do whatever you do?
Bleeding is the main name of the game in these situations. So if a supracervical hysterectomy is the fastest way to remove the uterus safely, then certainly that would be the sort of go-to option. As a budding GYN oncologist, if there's any chance to remove the cervix as well, then I would. I don't get it on test day, but I would certainly try to remove their cervix for my own sanity later in life. But yes.
I understand that. I understand that. Okay, great job. All right, good. And so then I guess maybe the only other thing that they could possibly talk about, you did talk about a blood transfusion. Maybe they would talk about at what blood loss would you institute mass transfusion protocol and why? How would you answer that?
So certainly if she's required 4 units of packed red blood cells within an hour and has evidence of ongoing bleeding or symptoms or evidence of hypotension, tachycardia, etc., then at that point I would notify the team that we need a massive transfusion protocol.
Okay, all right, great job. Good. I have no other questions. Thank you so much.
That was good.
Any questions for me? Thanks.
No, very helpful. This is definitely one of the scarier cases on the list that I remember. So I
bet you remember. All right, thanks. All right, let's see who else would like to go. Danielle already went. All right, I'm lowering everybody's hand. So seriously, anybody who wants to go, please raise your hand. We probably can do at least one more case, if not even 2. So let me run through here. All right, Jacqueline, let's get Jacqueline. Oh crap, hang on. I just cut out, sorry, I didn't mean to say that, but I just got rid of my case list. I got to go back to my links. Jacqueline, you're just muted on your end.
Hi.
Hey, how you doing?
I'm well. How are you?
It's fine. I got rid of you guys, so sorry, I didn't mean to get rid of you. I'm like, hey, I just closed out the case list. All right, and are you a generalist?
Yes.
All righty, let's see. There you are. Okay, so we just did an OB. You want to do an office or a GYN?
Office, please.
All right. Any particular case that's bugging you, or you want me to just throw something at you?
Just throw something at me.
All righty. Let's look at patient number 7. Your 71-year-old G2P2 comes in for her annual well woman exam. So The first thing I want to know about is a 71-year-old come in. I'm not going to talk about her problems yet. What type of screening would you recommend for a 71-year-old at a well woman exam?
So typically for a well woman, the type of screening tests that I would offer a patient are usually mostly in the history-based type of screening, tests. So if she reports anything that is concerning, like if she has things like breast masses or any sort of expressed concerns, then the test that I would order for the patient would be based upon that, of course. But for screening, the patient doesn't routinely, if she has no history of abnormal PAPs in the past, then usually between the ages of 65 and 70, I don't routinely do pap smear screening test. Patients typically get a mammogram for a screening test. They also get colonoscopies if they haven't had one recently, or if they've never had one, of course. They should usually start those at around the age of 45. And then also DEXA bone density scan starting at 65.
Okay. Okay, so let's talk about that. Let's go back to each one and tease it out a little bit. Mammogram. So when do you recommend the average risk woman start mammograms? How often should she get them? And when can she stop them?
At the age of 40 is usually the time frame that women per ACOG should start doing mammograms, and usually they get them annually. And then as far as stopping of mammograms, well, usually that's something that I think is also based upon the age of the patient. So usually patients, I would probably continue in a patient who expresses anxiety for as long as they wanted to continue them, but I probably wouldn't go past the age of 75, 80, depending on risk factors and things like that, because usually patients they usually are, unless they're really anxious, of course.
So let's just talk about that for a minute. When the whole purpose of screening mammograms is to detect breast cancer before it's even a palpable mass, correct?
Correct.
So the reason then, if when at age 75, we sit down and we're supposed to do our shared decision making with our patient with regards to should they continue mammogram screening or not, age and having two breasts and being female are like the biggest risk factors, right? So
Of course.
it's not like getting older makes you have less risk of getting breast cancer. So why would we actually ever consider stopping screening, looking for non-palpable, just mammogram detected breast cancer?
To be honest with you, I don't ever stop doing mammograms. I just doubted myself when you asked the question.
Okay. No. But here I want to actually give you like the scientific reason why we do that. The reason is obviously if somebody comes in with a palpable lump, we're going to get a diagnostic mammogram,
Mhm.
regardless of what their age is. The point of considering stopping screening mammograms is, but by the time a breast cancer is even detectable on mammogram, it can take
Pretty
several
big, right?
years before it would ever even become large enough that it would be palpable. And if your patient you really think has less than an 8 to 10 year life expectancy, most likely they're going to die from something else before the breast cancer would ever become an issue. That's really how you're evaluating it. So that's why ACOG says there really is no age you should stop doing it. You should evaluate the patient. And if you have, there's some 75-year-old patients I have, they are buff. They play pickleball and they walk and they do all kinds of stuff and they don't really have any medical problems. I would never consider stopping screening on them. But if I had somebody who had type 2 diabetes, end-stage renal disease, chronic hypertension, morbid obesity, is in a wheelchair, is 75 years of age, I doubt very much she's going to be alive 10 years from now. So what's the point to continue doing screening mammograms? Does that make sense?
That would make sense, yeah.
Yeah, so that's really with this, that's the screening mammogram. And actually the National Cancer, what is it? The National, the NCCN, what National Comprehensive Cancer Network, just put out a position statement this summer that they actually recommend all women start at age 40 and get their mammograms annually, which is different than the United States Preventative Services Task
Oh
Force.
yeah.
So let's just go by what ACOG says, or the National Comprehensive Cancer Network. Start at 40, get it annually, and at age 75 you can evaluate looking at life expectancy. Now let's go back to this DEXA scan. So you say at age 65 everybody should get a DEXA, but who should get a DEXA before age 65?
Patients who are at risk for I should specify, for patients who are at risk for fracture.
Okay, and what would some of those risks be?
Patients who are Caucasian, actually, was first risk factor, who have nutritional deficiencies or absorption deficiencies, problems with absorbing vitamin D, calcium, patients who may have some sort of autoimmune disease that might actually affect that problem, a family history of, fractures, or a personal history of fractures.
Okay, and so if somebody came in, say 57, they were thin, Caucasian, smoked, and maybe had poor dietary habits, would you just automatically do a DEXA, or can you be more scientific than that to determine who should get a DEXA before age 65?
I mean, I probably do. I could probably assess her for vitamin D deficiency first things first to see if that actually is an issue. Although, and talk to her about vitamin replacement first. And she's never had any history of any fractures. And even though she'd be at increased risk, she wouldn't necessarily. I wouldn't just run to the DEXA first.
So, have you ever heard of the FRAC score?
Mm-hmm.
Okay.
Yes, I have actually heard of it.
Okay, and there are two different ways we can use the FRAC score. One of the ways is to determine who should get a DEXA scan before age 65. Are you familiar with that?
I have heard about it, but I've never actually performed it myself.
Okay, all right. So one of the things that you can do is you can pull up the FRAX calculator, and even though you don't have a T-score, if you put in the patient's age, weight, all of her risk factors, you can actually calculate an estimated 10-year fracture risk. If it used to be, if it was greater than, I keep changing the thing. Probably you guys would know it better. It was like if it's greater than 9.3%, and then recently they changed it if it's greater than like 8.4 or 8.7%. I would have to actually double check that exact amount. But but it used to be greater than 9.3%. Why did they use that? Because that's the average 10-year risk of that's the 10-year fracture risk of an average 65-year-old. So if we're going to do a DEXA scan on 65-year-olds, then with that, then if they're 57 with the same risk for fracture based off of their number of risk factors, we should do a DEXA sooner. And so I'm pretty sure the new one is like greater than 8.4%. But regardless, it's right in that 8 to 9% range. And I'm sure if you put it in, it would come up with the exact calculation. All right, so let's say, why was a DEXA not done on this patient? Does she just not need it?
She just recently had one within the past 2 years.
Okay, and what
she
was this?
She also was not found to have osteoporosis.
Okay, what did she have?
She didn't even have osteopenia. She had actually had a normal range.
Okay, well, if she had a normal scan, a normal DEXA scan at age 65, they did one a couple years later, it was still a normal T-score. When would you do another one?
Usually they're supposed to be done, actually they're supposed to be done every 2 years at the earliest for a patient for a DEXA scan. I haven't read. I'm coming out of test mode for a second. I actually couldn't find that information because I was looking for that the other day.
Yeah,
for patients who had normal results.
Yeah, and the reason I'm going over this is because none of you guys deal with this stuff much. And that's why I wanted to pick the geriatric stuff, because you're dealing with obstetrics and younger patients and dysmenorrhea and infertility and syphilis and gonorrhea and chlamydia. So that's why I'm like, I'm going to spend some time on the old ladies, because you guys don't spend that much time with them. With regards to the DEXA scan, they do continue to change what the recommendation is. If anything, we do DEXAs less and less and less frequent. If you do an initial DEXA scan on somebody and it's actually normal T-score, there's some school of thought that you never have to repeat it again unless something changes in their life, like they're placed on steroids or, some other medical issue comes in. The soonest I would do one if somebody had a DEXA scan would be every 5 years. I
It
would
is fine.
not
Okay.
do it more than every 5 years. Yep.
Thank you, because I was looking for that because I had read in different places, different time frames, and I got completely confused. That's why I was like, I'm coming out of test mode, because I actually looked for that and I could not find it.
No,
So,
and it is very confusing because they continue to change it all the time. Now, what if you did do a DEXA scan on her and her T-score came back a -2 in her hip and a -2.2 in her spine? How do you manage somebody with low bone mass or what we used to call osteopenia?
so you can actually encourage them to increase their vitamin intake, and you can discuss with them considering starting medications actually to help with decreasing the osteoclastic activity, the breakdown of the bone.
So how do you know which patient who has low bone mass that you would recommend pharmacotherapy versus just vitamin D?
There is, I think we used, I'm blanking on that right now. Get back to me later for
Okay.
that one. I won't go
All
back to
right.
that.
That's where you use the FRAX score, but you use it differently because now you've got a T-score to plug into it. So basically, again, you put in her age, her weight, the family history of any first-degree relatives with fractures, go through the whole thing, and then you put in the T-score of her hip and you calculate her 10-year fracture risk. These percentages I definitely know. If her 10-year fracture risk for a hip is 3% or greater, or any major osteoporotic fracture is 20% or greater, she should be on pharmacotherapy as well as calcium, vitamin D, etc. Whereas if her FRAX score calculates less than that, then that is somebody that you would do, weight-bearing exercise, calcium, vitamin D, and repeat it in 2 years. So there's two different ways to use a FRAX. One to see who should get it done before age 65. The other one to see which patient with low bone mass should be on pharmacotherapy.
Okay.
All right. Now, this patient also was complaining of urinary incontinence. How did you evaluate that?
So for the, oh wait, I wrote that down. Oh, there she is. Okay. So for the patient, I had actually discussed with her her history, a little more detail to flesh out some more information regarding it. And she had reported that she was having basically urinary incontinence when she sneezed, laughed, coughed, and when she bent over to pick up any objects. And so after getting her history, I did a physical exam on her and noticed that she'd had basically like a level 2 of the Baden-Walker score, basically for prolapse anteriorly. And I discussed with her basically some of the options, including lifestyle modifications, starting with Kegel exercises, as well as other additional interventions, such as vaginal estrogen therapy and pessary, and particularly any potential for procedures. And after our shared decision making, we discussed basically that she wanted to meet with urogynecology.
Okay. Prior to sending her to Urogyne, did you, in addition to doing a pelvic exam, did you do anything to evaluate for stress incontinence itself, and did you do any sort of evaluation of the urine itself?
So for the patient, because she'd elected to go to urogynecology right away, she, declined to leave any urine. I don't really know, the reasoning behind it. It was a discussion with my staff, I think, with the lab itself. But basically, what had occurred is that I usually offer patients, when I work them up for urinary incontinence, a urine culture to verify that there isn't another cause potentially for the incontinence, because urinary tract infections
Right.
can certainly do that. And I would offer the patients additional testing, like things like the Q-tip swab with the little lidocaine gel to decrease some of the discomfort. And then I can also do sort of assess for other potential causes of urinary incontinence, things like, the anal wink, the anal wink itself, make sure there isn't anything else. I usually do something where I take the speculum apart, and I can actually try to decrease any sort of prolapse to get a sense of if there's any improvement for the patient. So I have them cough, or laugh, or I'll have patients even potentially stand up and try to cough and laugh. And I also assess to see if they do any splinting or anything to see if they need to urinate. I'm actually looking at not just the anterior, but also the posterior as well for any other potential prolapse.
Okay, yeah. So if somebody comes in with a urinary incontinence, you're absolutely right. You're going to do a history first. The history that you have was very consistent with more of a stress incontinence, but any type of incontinence, we need to do a UA and a urine culture to rule out UTI as causing these symptoms or even exacerbating them. And that's you offered it, but for some reason she declined it. You're going to do a pelvic exam. You're going to look for pelvic organ prolapse. Oftentimes when the patient is even in the lithotomy position, you can ask her to cough. And if you may see leakage of urine. If it doesn't occur in lithotomy, you do it when she's standing. As for the urethral hypermobility, you don't even have to stick a Q-tip in. You can, and that's always what we've been trained. But even with Valsalva, if you can see, excessive motion of the urethra, that is another good indication of urethral hypermobility. And she was going to urogynecology anyway, who will also talk to her about pessary versus surgery. Now, she had vaginal atrophy and dyspareunia, and you listed hormone replacement therapy. What did you mean by that?
Particularly, I offered just vaginal estrogen.
Okay.
Like a cream, basically.
Yeah, that's what I was hoping you meant. And most of the candidates will write vaginal estrogen versus HRT, because oftentimes we look at that more like systemic hormone therapy. But yeah, vaginal estrogen should help her atrophy, dyspareunia. If she had a lot of urgency and frequency symptoms, it could very well help that. And plus minus, it can help stress incontinence. Probably not so much, but it will definitely make the tissues a lot healthier and stronger when Urogyne goes to do their TVT. So good. All right, I probably should stop there. But one last thing I would just want to go over with all of you guys. At every wellness exam, it doesn't matter if the patient is 18 or 81. There are a couple of different things that ACOG wants us to screen for as part of our screening. We're supposed to screen for intimate partner violence, depression, substance abuse, update vaccine history, and update their family history annually, looking for any evidence of hereditary cancer syndromes. So just try to put that in your head as something that is you would do for screening, part of your screening procedures, and then the rest of it, of course, would be your age-appropriate screening.
I have a quick question about that. So for a patient who's 71, I know we always ask, but how relevant is familial cancer screening at 71 now for the lifetime risk of things like ovarian cancer and breast cancer?
It's probably not near as relevant for her. But if she did say, oh yeah, you know, my daughter ended up with breast cancer and my other daughter had ovarian cancer or something like that, it
Mm-hmm.
still is an informational that may help with counseling. But I see what you're saying, but they don't say any age of which you should discontinue it. They just say update family history looking for familial cancer syndromes.
Perfect. The only reason why I asked is because I just wanted to be prepared just in case they asked me something like that. I'd be like,
no,
well,
they
you know.
could say, well, why do you care? Why do you care? You know, if she's 71,
Exactly.
why would you care that this or that happened? And you could just say something like, you're absolutely right. And somebody that of this age, it would certainly be less relevant to her overall care, but it still could be important information for her children and her children's children.
Perfect. Thank you.
Okay, thanks, Jacqueline. All right, you guys, I'm going to go ahead and call it there. It's a little bit past 10. I will be back doing case list reviews on, I think, Sunday. All right, thanks so much. Everybody have a good night, and I'll talk to you on Sunday.